Right. So I will call upon Dr. Anand Ramamurthy for his presentation on liver resection techniques, CUSA, water jet, and others, energy sources used for liver resection. Dr. Ramamurthy.
Okay, good afternoon, everyone. Thank the organizers, Dr. Sanjay Mandal, for giving this opportunity. And he called up and asked me to speak about liver parenchymal transection techniques. So what I'll do briefly in this presentation is give us a brief overview of what are the transection techniques available, and then proceed to show you some videos of the commonly techniques that I commonly practice, and go from there. So it is well established in a Cochrane review that clam crush seems to be the method of choice. But in the clinical scenarios that we face, the answer is not that simple. So we have to tailor it to the patient, the liver quality, and the purpose we are doing for. What is the objective? Like, for example, in a donor hepatectomy, I would not do a clam crush technique, nor would I use a non-selective energy source. So the objectives that we are looking at when we are doing parenchymal transection is that it should be as fast as is possible while maintaining accuracy and while remaining safe, which means minimal blood loss, post-transfusion requirements, and reduced post-operative morbidity as well as ICU stay. So these are the commonly available techniques. The traditional techniques are finger fracture and clam crush. And there are tissue selective techniques. Commonly used ones are CUSA and hydrojet, and energy devices, some of which are harmonic, tissue link, aquamantis, among others. So the advantages of traditional techniques is that they're fast, they don't cost much, but they need some kind of vascular inflow control to reduce the bleeding, and of course adjunctive techniques like clipping and ligation for hemostasis is required. Coming to energy devices, they use some form of energy, radio frequency or ultrasonic. They are non-selective in their ablation. They leave behind some degree of devitalized tissue, which can slough off and later lead to secondary bleeding or bile leak. They may not require any additional tools for hemostasis, and depending upon the technology used, they may be variably expensive. Coming to tissue selective techniques, the commonly available ones are CUSA and water jet. CUSA is probably the most commonly used technique today. They use differential properties in the collagen of the liver parenchymal tissue as well as the portal structures and the veins in order to dissect. They do need adjunctive techniques like electrocautery, clipping, or ligation for hemostasis. We do them often avoiding vascular controls. The transaction time taken may be longer, and some degree of operator experience is required, and the tools may be expensive. So water jet is again a different technique compared to the CUSA. It is also a tissue selective technique, but the difference lies in that it uses a jet of water to disrupt and wash away the liver parenchymal cells, which leave the traversing portal or venous structures clear to manage. So typically the water jet has a coherent dispersion after it remains coherent for a distance of about 2 to 3 millimeter, after which it starts dispersing. And I'll come to the technique in the video when I show that. There are certain advantages, like it's a light probe, it's very light and easy to handle, operator fatigue is low. The water used in the water jet washes away the blood and the clots and leads to a clear visible field. It can be used close to vital structures such as hilar plate, pedicles and veins without risk of injury or bleeding, which is less so than CUSA. Well, disadvantages, there is splash of water, which is often an initial bother for most of the operators till they get used to it. And there are certain techniques in which you use it correctly so that you can avoid the splash of water, and which I have listed it out. And speed of transaction is variable. Some say it's slower, some say it's faster than CUSA, but bleeding is more or less similar. We performed a randomized controlled trial in our setting with both, which did not bring out any significant differences between the CUSA and water jet. So these are the comparison between the two, and more or less they balance each other's out. So although the CUSA is initially more expensive, but the disposables are less. Water jet, the cartridge at least needs to be replaced every time. That comes to around 35,000, and the tubing can be used for about 3 to 4 times. So the difference comes in the use. In CUSA, you've got to touch the liver tissue with the edge of the vibrating tip of the probe so that it can act. Whereas in water jet, you must not touch the liver tissue with the tip of the probe. It has to stay 2 to 3 millimeters away from the tip of the tissue, otherwise it will cause damage by the suction. So CUSA needs to be used very carefully adjacent to the veins, portal structures, or the hilar plate, whereas with the water jet, you can be more liberal in its use. So I'll just come to I'll show you some videos of that. So the first video why isn't this playing? नहीं मुझे I don't need the play. Is it okay? Showing audio नहीं लगेगा. So this is the water jet being used for transection in a right lobe hepatectomy. For some reason, I'm not able to play it in the full screen. Let me try again. So I'm sure you can see this clearly in this. So this is a water pressure that we use commonly is about 35. It suits all our requirements. If it's cirrhotic liver, okay, great. So let me just go back a little bit so that I can explain those points. So this is a right lobe living donor hepatectomy that we are doing. And here we've done all the initial steps. So I'm focusing on the parenchymal transection. We need to score the capsule with a cautery because either water jet or CUSA will not work effectively when the capsule is there. So that is the probe that we are using. So you can see the stream of water jet. It washes away and leaves behind the structures that are visible. Any structure that is less than 2 millimeters, we can electrocauterize. You can see the cautery in the hand of the assistant. And this is the effect that we use it at. So as these structures are exposed, the assistant kind of keeps dividing them by electrocautery. If we encounter a structure between 2 and 3 millimeters, then we clip it and divide it in between. And if it is larger than 3 millimeters, then we will go and we will ligate it. So one of the advantages is, as you can see, while the water comes and washes away the structures, it leaves behind a clear visible field. So it's easy to kind of visualize the structures, especially in a living donor kind of setting where you need both the sides need to be well preserved. So here you can see a structure that is a small vein traversing the field, which is more than 2 millimeters. So we are clipping it and then cutting it. So as a principle, we don't use anything more than 100 clip to kind of divide it. So here just washing the field to kind of make it look, make it clear, wash away all the residual blood. So then we keep on proceeding with the transaction. What I want to observe here, or what I want to demonstrate here is, as you see the main vessels, the segment 5 vein and the segment 8 vein coming, that is the area where it is most useful. So this was a slightly larger structure, more than 3 millimeters, so we are just tying it out. So we can see the branches, we can see the segment 5 vein there coming into the field. So you can see how maneuverable the probe is. We can use it above, below, something that we use even during this thing, what we call as, we use a jet of water to clear out the stream. So the visibility, as you can see, will be much better. So I'll just speed this up a little bit. So here, this is the last part I wanted to show you in this video. Here you see the segment 5 vein. We are not directly using it on the liver, but we are using it behind it, above it. So all those places to just isolate the vein and expose a length enough for us to loop it and eventually divide and clip and divide it, which will be done towards the end part of the transaction. So this is what is called as a paintbrush technique movement, the side-to-side movement. When we are cutting through the liver tissue, we can use it straight like a knife cutting through butter. And when we encounter a structure and we want length to clip it, then we would use a side-to-side painting movement to expose, clear off the liver parenchyma from the surface and expose. So you can see the segment 5 and 8 veins here have been exposed. So I'll go to the next one now. So this is another video in which we are doing a benign liver tumor, adenoma of the liver. So here what we are doing, I'm trying to demonstrate the Kelly-Kleisis technique. So I generally prefer to use the Kelly probe should not be neither too thick nor too thin, exactly as I've shown here, and about 8 to 9 inches. And then we take small bites at a time. So good retraction, suction is enough, usually used in conjunction with the Pringles, but in this case, we did not use Pringles. It was not required. But in all cases, the anesthetist have to give you a CVP that is less than 3, as close to 0 as possible. We stop infusion of IV fluids. The mean arterial pressure is maintained around 60 to 65, and that leads to the liver becoming softer, more easily handleable, and less bleeding at the time of transaction. Again, the principle remains the same. So we crush a small amount of liver tissue, and when the structures get exposed, any structure that is less than 2 millimeters gets diathermized or cauterized, and any structure that is above that gets clipped. And finally, I would like to show the video of the So this is the CUSA probe. Many of you may be familiar with it, but as you can see, this is a slightly bulky probe. This is a CUSA XL. There are other companies also available, depending on whatever is available at your institution. All are more or less equivalent. So this is the tip that I'm showing, which should come in contact with the liver tissue in order to break it down, and then the suction kind of takes it away. So again, the same things, whatever bigger structures have been clipped or ligated, and the smaller structures are kind of cauterized by the operator. So in this side, the adenoma side is going to go away. So we may sometimes clip on one side and cauterize on the go side. So that's my time. It says my time is up. So I'll kind of stop here and invite questions from.
I think you have got still a couple of minutes. Yes.
Okay, then it's fine. I think the technical sorting out took some time. So this is what we are going with, more or less the same lines as I've said. With the remaining non-selective energy devices, I do not have. These are the 3 most commonly used techniques in clinical practice, and the only ones which I use. Sometimes we may use a hybrid technique. So like in this case, I've demonstrated on the same patient a combination of Kelly-Kleisis as well as CUSA. And in the previous video, I showed an example of the water jet being used. So let's leave it running here, and then we can discuss.
Yeah, any questions from the floor, please? I personally have used both the waterjet and the CUSA. I find, as you said, the CUSA is so heavy, the handle, and it becomes fatigue after some time. And hydrojet is, in that way, is very useful. But I think CUSA is much more effective, in my experience.
In the randomized trial that we published, CUSA was faster, and in our experience also, it is borne out that CUSA is slightly faster than the waterjet in terms of absolute transaction time, volume for volume. But again, yes, I would prefer the waterjet in situations where accuracy and least amount of collateral damage is required. One of my favorite examples would be donor hepatectomy, although I equivalently use both depending on availability and mainly availability. But if my preference, each person, surgeon over a period of time develops a particular liking for an instrument. So my liking for that instrument in a donor hepatectomy is waterjet. Again, in complex tumors where I have to go close, which are located close to the veins and kind of precise dissection is needed, I would prefer the waterjet. In cirrhotic livers, both CUSA and waterjet are kind of slower than in normal livers. But in, say, elderly livers, friable livers, steatohepatic livers and all, again, waterjet may be useful. But yes, you are right, the speed of the CUSA is actually slightly better than waterjet. So another thing that was borne out in that trial was that although it did not reach statistical significance because of the number of patients in the trial, the incidence of biliary injuries was lower in the waterjet group compared to the CUSA group.
Another question. I'm sure you also do laparoscopic liver resections?
I don't do major liver resections. I've
right.
done only
Now, the one
resections.
question is, as a basic principle of parenchymal dissection, anything less than 2 to 3 millimeter, you can cauterize. Anything more than 3 to 5 millimeter, you have to ligate or clip or tie. Now, what happens when it's used, the energy sources that like harmonic or thunderbird being used, and what is the effect, the outcome about so far as the bile leak is concerned?
Not really much. I mean, in the sense that I have used these energy sources like harmonic are in conjunction with cheliclysis, for instance. For instance, the patient is unaffordable. So as I said, the use of each of these devices would be associated with a certain cost, and we want to save them certain. So then we can use I've used the cheliclysis in conjunction with a harmonic. But I would not use the harmonic for deeper structures. I would use it near the surface, maybe for the first centimeter or so. So even if bile ducts or any other structures come, they are the peripheral supply, and if there is a leak, it would be self-contained, it would be self-limiting. So it does not have a clinical impact. But that is the psychology that comes with it. As transplant surgeons, when we do volumes of donor hepatectomies where no mortality is acceptable and any kind of morbidity is frowned upon, we kind of translate that into all the other surgeries that we do. So we want to carry out every hepatectomy with that same kind of precision or, minimizing the morbidity. So yeah, we do tend to take a bit more time than, say, for example, an oncologic resection.
Well, absolutely correct. Thank you very much. I think we should conclude now. The time is up. So we move on to the next session. Thank you very much.